So welcome everybody. We've got another lecture in the series of educational rounds in cardiovascular MRI for the Society of Cardiac MRI, Canadian Society, and also as part of the Stephenson Cardiac Imaging Center lecture series. Today we have Dr. Lou Kolman, who is going to be talking about hypertrophic cardiomyopathy, new guidelines and CMR markers for sudden death. A highly relevant topic and one that we've been very much focusing on not only locally within our center, but on an international scale with the recent and ongoing enrollments in the NIH registry. So this is very timely. And so I want to thank Lou for giving this talk. Lou is one of our previous fellows and now is a very active member of the center, both academically and also clinically doing reading. And so we're very happy to have him talk today. So please go ahead.
All right, thank you, James. So yeah, we'll be talking today about hypertrophic cardiomyopathy. There's been some new guidelines that have come out in the past year, and I think there's some really exciting cardiac MRI biomarkers to be talking about, and we're going to move ahead. So the outline for the talk, I'm going to talk about a case, a patient that I saw in my clinic, kind of highlight some of the issues that we're going to talk about today. We're going to talk about the scope of the problem, particularly about sudden death and hypertrophic cardiomyopathy. We're going to talk about the current risk factors and what's the data behind them, the new European guidelines that came out in 2014, and then some really exciting novel CMR biomarkers. So this is a patient that came to my clinic. He's a 19-year-old male nursing student, and he was totally asymptomatic. He had some very marked voltages on his routine, his routine EKG. It was the EKG was done because he was a type 1 diabetic, and so they did an EKG, and this is what they saw. And you can see these really marked. Oh, okay, there we go, perfect. So marked voltages in the QRS complex and repolarization abnormalities. So his past medical history is a recent type 1 diabetic. He has an insulin pump. On social history, just to make it interesting, he's a competitive soccer player. And his family history is basically unremarkable. He has 2 healthy parents. He has 1 sister who's healthy, and he's doing great. So on his echocardiogram, he had severe left ventricular hypertrophy. He had a septal wall thickness of 2.2 centimeters. I'm going to show you some pictures in just a moment. So he had a Holter monitor that showed no ventricular tachycardia, no atrial fibrillation. He did a treadmill test with me, which is pretty incredible. He exercised for 18 minutes on a Bruce protocol, which is just phenomenal. He had no arrhythmia. His blood pressure response was totally normal. And then he had a cardiac MRI, which was actually very abnormal. He had an 18% late gadolinium enhancement burden, which was actually predominantly subendocardial and mid-myocardial. So this is what his cardiac MRI looks like. So this is just one picture, of course. This is a 4-chamber view, looking at the left ventricle, the right ventricle, left atrium, and right atrium. And you can see that he has really significantly increased wall thickness, almost kind of throughout. His right ventricle has increased wall thickness as well. He's got a fairly hyperdynamic left ventricle. And if you compare the image up top to the image below, you can see here in these late gadolinium enhancement images that there's this increased signal at the apex of the heart. So the normal myocardium is in black on the late gadolinium enhancement images, and the abnormal scarred tissue or late gadolinium enhancement areas are in white. And then the subendocardium here, and here there's this kind of patchy, diffuse subendocardial pattern that goes around the apex into almost the mid area. So now the question is, what is this patient's risk of sudden death? And you have to imagine, I'm sitting in the room with the patient and his 2 parents. He has a new diagnosis today of hypertrophic cardiomyopathy, and he wants to know, am I going to die? Am I going to live a normal life? And there were a lot of tears in this appointment. It was a hard conversation. And you know, if his risk is high, should he be offered a defibrillator? So let's go through some of the data and the scope of the problem to try to help this gentleman. So we're going to talk about the scope of the problem. So hypertrophic cardiomyopathy. For the purposes of our talk today, we're going to talk about hypertrophic cardiomyopathy referring to the sarcomeric protein gene mutation cardiomyopathy that has an autosomal dominant inheritance pattern. So we say that hypertrophic cardiomyopathy is defined by a wall thickness greater than 15 millimeters, which can't be explained by loading conditions. So here you have a patient with a normal wall thickness, and you can see here it's very different. This is the septum of the left ventricle and the lateral wall. The septum is just much, much larger than the lateral wall, so much greater than 15 millimeters, and very abnormal. So the phenotypic spectrum of hypertrophic cardiomyopathy is extremely varied. So you can have patients who have increased septal thickness compared to their lateral wall. You can have patients just with a sigmoid type septum, almost tumefactive hypertrophic cardiomyopathy, as some people like Naeem say. We can have apical and apical variant of hypertrophic cardiomyopathy, where you have almost a spade-like appearance of the left ventricle and hypertrophy of the apex. You can essentially have hypertrophy of almost any area in the heart. So pathologically or pathophysiologically, we can see differences between what's normal in the heart and what's not normal. So in the normal heart, you have these nice myocytes that line up very much in parallel. And in the hypertrophic cardiomyopathy patients, you get myocyte disarray. And so here's where these myocytes are, and they're not parallel to each other anymore. And then you get these areas of increased, the lighter pink areas are in collagen. So you get collagen deposition and scarring in these areas. So if we look at the sarcomeric structure and we think about our genetic mutations, the most common reasons for having this is a genetic mutation in the myosin binding protein C mutation and the beta myosin heavy chain. So that encompasses 80% of these patients who have a genetic problem. So hypertrophic cardiomyopathy is the most common cause of sudden death in athletes. So if you look at, and it occurs in about if we look at all field deaths, it occurs in about a third of the field deaths in the United States is attributed to hypertrophic cardiomyopathy. So I think this is very, very interesting. So this is Hank Gathers. He played basketball for Loyola in 1990, and he was a star. The guy, he was 6'7". In the year before he passed, he scored in a game 48 points and 13 rebounds against a young Shaquille O'Neal. The guy was a real star. In 1990, moments after doing a tomahawk dunk, he comes down and he basically passes out, and he goes into VT and VF, and he collapses and dies on the court. And this was extremely publicized. The pictures of him going down on the court were put all over ESPN, and it really brought a lot of broad recognition to this disease. So this patient really gives us a window into a lot of the patients that we actually really don't see. So hypertrophic cardiomyopathy occurs in 1 in 500 patients. So that means there's 700,000 Americans walking around with hypertrophic cardiomyopathy. Your real risk of sudden death is extremely low. It's probably on the order of 0.5% per year. Maybe 5% of these patients might die of sudden death. So it's actually very, very rare for this to occur. There might be 15 deaths, field deaths, in the United States the entire year. Compared to how many athletes are out on the field, that's extremely low. And so patients like this really, I think, give us a window into a lot of the patients we actually don't see. So hypertrophic cardiomyopathy is the most common cause of death amongst young people. Most patients with HCM have a low risk of ventricular arrhythmia and sudden death, but there is a small subset who have this risk of sudden death, progressive heart failure, atrial fibrillation, and stroke. So if we look at patients and their course, so this is a study done in 2003. It looked at 300 patients, and it looked at their survival. And in patients in the general population in the dotted line, you can see, compared to the patients with HCM, you can see that their patients with HCM, their survival is worse, slightly worse, okay, over their time from diagnosis. So if you risk stratify these patients, in patients that are older than the age of 50, there we go, their prognosis is the same. But if you take patients that are younger, their prognosis is slightly worse. So there's something very protective about getting to age 50 or being older when you're diagnosed with disease. It may signify a sort of a less malignant phenotype. And so the only effective measure for prevention of sudden death and disease is the implantable cardiac defibrillator. So now this is it's really a miraculous treatment, right? But there's risks in putting in an ICD, particularly in someone who's young. And these are the risks of an ICD. The mechanical complication rate is 5.1. The device malfunction can occur. You can get inappropriate shocks. You can get an infection. There's going to be device changes over years. And you can imagine if you're a 19-year-old kid and you're thinking about getting an ICD, it's a big deal. So robust tools are needed to predict which patients are with HCM are at risk. So there was a landmark study done in 2000, or published in 2000 in New England Journal, that looked at ICDs. This is the only randomized trial that was ever done in the hypertrophic cardiomyopathy patient. And so it looked using ICDs. So it showed that that you could prevent death with an ICD with a number needed to treat of 4. It was actually really remarkable. And I think one of the things that's really interesting about the study is it was done in an area that was early for the development and the evolution of ICDs. For the most part, ICDs were being done for patients at this time who had ischemic cardiomyopathies, and there were some non-ischemic cardiomyopathies. But the idea of doing it in this patient population is actually quite radical. I mean, these patients have left ventricular outflow tract obstruction. They have extreme hypertrophy. They have microvascular ischemia. It wasn't a slam dunk, I think, that ICDs were really going to work in these patients. So it's pretty amazing that this trial was positive and has spurred on the continued research that's ongoing for hypertrophic cardiomyopathy patients. So the thought is that if you can risk stratify these patients into either a low, intermediate, or high risk, you can take the high risk patients, you can give them ICDs, and you can reduce their risk of sudden death to 0.5% per year. And ICDs have really made this disease into a contemporary and treatable disease. It was thought to be a death sentence for a while, for many years. So in patients who get an ICD, your risk of shock per year for primary prevention is 4%, and for secondary prevention is 12%. So what's the data? So in 2011, the ACC/AHA came out with their statement on how to diagnose and treat cardiomyopathy patients and came up with guidelines for risk stratification. And the utility of these risk factors is interesting because the risk factors are not robust, right? None of our risk factors are robust. They have low positive predictive value and they have high negative predictive value. So most with one risk factor will not experience sudden death. And that's so among an international ICD registry, the number of risk factors that you had didn't correlate with ICD events, and 25% actually received inappropriate shocks. So one risk factor might be enough to warrant an ICD, but the decision really needs to be individualized. So looking at very individual risk factors, I'm going to show you the data on each one of these risk factors. So if we look at syncope, I think this study was interesting. This looked at 1,500 patients, and if you had syncope less than 6 months of your time of being evaluated, you had an increased risk of sudden death. This is a survival curve. You had a hazard ratio of 4.8 compared to if you had syncope a long time ago versus if you never had any syncope at all. And risk carried forth if you were less than 18 years old, intermediate age, or greater than 40 years old. So what about family history? Another, I think, really actually great study. And I think this is a subtle point. This slide brings about a subtle point that I think that I learned actually from this talk. So this looked at a Polish cohort. Many different institutions contributed to this population in Poland. So 1,300 patients. Now look at this. If you look at the scale here, the scale is in time, years of life. So if you had no family history of sudden death, your risk was much less. If you had one relative, your risk was worse. And if you had two relatives, your risk was a lot worse. So having two family members with sudden death was a lot worse than having one. So non-sustained ventricular tachycardia. So we often look for, a lot of these patients, or all of our patients, do ambulatory Holter monitors on a yearly basis. Most clinics are doing that. So NSVT is very common. I think that's the first point. This looks at just the prevalence of NSVT in patients going from ages 14 to 75. And you can see that, you know, in the younger patients, 15 to 17%, and in the older patients, a quarter of them had it. I mean, it's a lot of patients.
And yet the older patients aren't dying.
Yeah, and yet the older patients are dying. That's correct. Yeah, that's exactly it. And so we actually, so this looks at age risk stratification, right? So in the same study, they looked at patients yet less than 30 versus older than 30, and they basically, if you were less than 30 in NSVT, your risk ratio of death was 4.3, whereas it was non-significant if you were older than age of 30. So not predictive in the older patients. So this looked at, so then we also do treadmill testing on patients, and we look for arrhythmia in those patients as well. And in this United Kingdom referral population, if you had non-sustained ventricular tachycardia or ventricular fibrillation on a treadmill, you were more likely to die. So another study looked at blood pressure response to exercise. So that's another risk factor that we always look for when they're doing their treadmill stress test. And you know, interestingly, a lot of these patients have an abnormal blood pressure response. It's actually a fairly common thing, but it is found to be predictive. And in this study, there was a 97% negative predictive value, but only a positive predictive value of 15%. So another thing that we always look at is that, I mean, we always talk about this in the imaging world, is the magnitude of LV septal hypertrophy. And so we believe, so in this chart, we're looking at the LV wall thickness as it goes from less than 15 to over 30. And this is a little difficult to read, but basically, I think what you can gather here is that there's a gradated response or gradated dose of risk as you increase as your wall thickness increases, as your septum increases. So it really shouldn't be a binary risk factor. It shouldn't be, oh, if your septum is greater than 30, your risk of death is worse. It's as your septum goes higher or increase in width, then your risk of sudden death goes up. So how do we use these risk factors? So some people have said, some studies have said, okay, we should take these risk factors and try to combine them. And if you have, and this is what's been endorsed essentially by the ACC/AHA guidelines, is that if you have no risk factors, your estimated survival is 95% over 6 years. It's unlikely that an ICD is warranted. If you have one major risk factor, your survival is not quite as good. It's not terrible. You know, maybe an ICD is reasonable. And if you have more than one, then certainly it sounds like an ICD should be in your future because you're at higher risk. Other studies have, so this is that same Polish cohort that I talked about earlier. They did something similar, looking at numbers of risk factors. So there's problems here, right? And so that is, and I kind of mentioned this earlier, multiple risk factors don't predict risk. This is a population of patients, this was published in in JAMA in 2007, looking at HCM patients who all had ICDs and looking at who got shocked. And it shows that if you have one risk factor, two risk factors or more, there's really no change in your risk of getting shocked. So we're continuing to try to think differently about this disease, and so there were some new guidelines that came out that I think are worthwhile to talk about. So these are the 2014 European guidelines. So in their risk stratification schema, they have a recommended assessment. They have some risk variables, which I'm going to talk about, and then they have a risk score. So if we look at their variables, there's age, there's family history of sudden cardiac death, unexplained syncope, left ventricular outflow tract gradient. We didn't talk a lot about that at this point, but that's another, of course, risk factor. There's left ventricular wall thickness, left atrial diameter, and I'm not all that familiar with a lot of literature talking about sudden death related to that, and then NSVT. And the idea is that they will come up with an HCM risk score similar to a CHADS-2 score to come up with your risk of sudden death, and if your risk is low, then less than 4% per year, then you generally don't need an ICD. If it's intermediate, 4 to 6% per year, then ICD might be considered, and then if you're greater than 6%, then an ICD should be considered. Oh, I meant to blow that up there. Okay. So so they have the online calculator, and anyone can go to this and fool around with the numbers, and it's again very similar to a CHADS-2 score. You can reach it on hcmrisk.org. It's also just, I actually tried the link and it didn't work for me, but you can Google it and easily find the calculator. So you can just basically plug in your patient's information and come up with an individualized risk. So I think there's pros and cons here. So pro. So ideally, there's an improved ability to discriminate the risk, and at least the published C statistics here. So there's an improved C statistic going from 0.69 versus 0.54 for the AHA-ACC conventional risk score. So it also treats certain variables as continuous rather than binary, so i.e. wall thickness. I think most people in the world who are treating hypertrophic cardiomyopathy tend to think of wallness as a gradated risk factor, but technically the AHA guidelines doesn't. So there's also accounts for the relative contribution of each variable. So maybe not each variable is as important as the other variable, and so it's able to do that in a discriminatory way. So cons. So this is only derived from one cohort. Now it's a multinational European cohort. There were over 2,000 patients in it. There were 109 deaths. So that's good, but we're applying it to the entire, potentially applying it to, say, Americans or Canadians or African Americans. I'm not sure if it translates. It's hard to know. It's only been validated in one population, and that's the British cohort. This was almost 1,600 patients. They had 89 sudden cardiac death events. So the other part of this is it incorporates left atrial size, and if you play around with the tool, the left atrial size really changes things quite a bit. And so there's definitely an impact there of left atrial size, and I'm not really sure how much that should impact things. Okay, so moving on to the last part of the talk, I'm going to talk about novel CMR biomarkers. So cardiac MR has made, so it's really emerged as a powerful complementary tool, due to its enhanced spatial resolution that affords better characterization of the complex HCM phenotype. It has improved precision and accuracy of LV wall thickness. There's improved interrogation of the HCM morphology. We can see RV hypertrophy better. There's high-risk apical aneurysms that can be seen more easily. Aberrant papillary muscle is different, and we can differentiate, say, for instance, the apical HCM patients from someone who might have non-compaction. And these are just some examples. This is a patient with an apical aneurysm here at the tip of the left ventricle. And we've talked about the septal hypertrophy before. This is someone who has significant late gadolinium enhancement in the septum. This is someone who has significant crypts. We can see these a lot better in cardiac MR than we can see in patients with echo. This is a patient whose echo, you can't really even see the anterior wall so well. You might not even know this patient has hypertrophic cardiomyopathy, and with CMR, the wall thickness is much greater and better seen. So in CMR, we have the ability to do late gadolinium enhancement imaging, and if we look at patient, so this is a late gadolinium enhancement image. The areas of normal myocardium are black, and compared to an area that's white here that has late gadolinium enhancement. So on this top image, we're looking at the pathophysiology of a patient, of looking at their, quote, normal myocardium, or their areas without LG. It's actually not normal myocardium. They have a lot of myocyte disarray, compared to the areas that have late gadolinium enhancement. They have increased deposition of collagen. So we think there's the areas that have LGE correlate with areas that increase collagen deposition. So we know that the presence of LG on CMR is associated with increased sudden death in patients with HCM. So this was a large meta-analysis done showing that there's increased risk of cardiac death, increased of heart failure death, and increased all-cause mortality. But there's a problem with late gadolinium enhancement, and that is that 50 to 75% of patients with HCM have late gadolinium enhancement. So its utility is reduced or limited by the fact that most patients with HCM have this risk factor. So that brings you logically to the question, does the extent of LG correlate with sudden death? Rather than binary, do you have LG or not, does its extent correlate with sudden death, and particularly in patients with not a lot of risk factors? So similar to the patient that I was talking about when I first presented when I presented my case in the beginning of the presentation. So that question was attempted to be answered in a paper that came out in 2014, and I think this is a landmark paper and worthy of going over. And this looked at the prognostic value of late gadolinium enhancement in low-risk HCM patients. So this is a study cohort of almost 1,300 patients studied in 2001 through 2010. There were 7 sites, so it's a multinational study. The mean age of these patients were about 46. They weren't that symptomatic. Their NYHA score was only about 1.6. They had relatively very few risk factors, 0.5 plus or minus 0.6. They followed them for 3.3 years, and as you would expect, the prevalence of LGE was 42%, so it was quite high. So this looks at their method this just kind of shows their method of quantifying the scar. So this is a short axis left ventricle image. The red line looks at the subendocardium, the green line looks at the epicardium, and the areas of white represent the scar. And they used a sliding manual threshold method to try to map exactly and quantitate the scar in these patients. It's thought that this correlates best with a 4SD method. And so these are just some of their case examples, just to give you an idea of the percentage of scar in these patients. So in a 29-year-old man, this patient has 4% scar. In a 54-year-old guy, this patient has really significant amount of scarring, 36%. In this 29-year-old guy, he has 32% scar, really, really significant. And this is another patient with just very, very dense scar. This person had 23%. So it just gives you an idea, at least, of some of the cases. And when we look at the results of this study, there was a dose response, and I think this is important, that there was a dose response between the amount of late gadolinium enhancement that you had and your risk of sudden death. So this is a survival curve. We're looking at late gadolinium enhancement that's either absent or as it gets worse, going down, and you can see your survival curve is worse as you go down. And your incidence of sudden death increases with the extent of LGE. So this is 0% LGE, and as you get worse. What I think is interesting here, sorry, I wanted to bring this up, is that though even in patients without LGE, there was still sudden death. So LGE is not the total explanation for why patients, or LGE or scarring isn't the total explanation for sudden death in these patients.
That's the assumption that we see all scar with LGE.
That's the assumption that we see LGE, yeah, that's exactly it.
True. We see many patients with infarcts.
That's right.
We actually see no LGE.
Yeah, it's true. So, so within the means, the sensitivity of the tools that we have with LG, of course, right? And so what comes out of this study is, I think, a really important graph, and that is we can estimate our 5-year survival rate of sudden cardiac death, of total mortality, and end-stage hypertrophic cardiomyopathy, which is basically development of an ejection fraction less than 50% over time, based on how much LGE you have. So I think this is really important for our patients with HCM to help risk stratify them. And I think can be incorporated clinically into our reports at this point. So I'm going to tell the story about T2 weighted imaging. So we're going to switch gears. So T2 weighted imaging refers to water mapping, essentially, of the heart. Or we usually think of it as edema mapping or water mapping, but it might actually be something very different, and I'm going to talk about that here. So the story starts, so I'm going to give some example images here. So in this late gadolinium enhancement image, the black myocardium is normal, and the white area shows, again, late gadolinium enhancement. And you can see there's significant late gadolinium enhancement in these images. So back in around before 2008, in the imaging center here in Stephenson, the group here published a cohort of patients that had increased T2 signal in patients with hypertrophic cardiomyopathy. So they noticed this very distinct imaging pattern that showed up, where you have T2 signal that was mapped to areas of very dense scar. And this occurs in about a third of patients. It's only, again, consistently located only in areas of dense fibrosis that you see this increased T2 signal. Now, I mean, this is pretty strange, though, right? Because if we think about edema, why would you have edema in the middle of very dense scar? It's very unusual. If you have dense scar, you shouldn't have inflammation going there and an edematous process. So what is happening in that area? And I think that's a bit of a mystery. It was also shown that in these patients, there was a greater association with more hypertrophy, and in subsequent studies, it's been shown that, again, this occurs in about a third of patients, so in other cohorts, independently seen. And then it's also been correlated with non-sustained ventricular tachycardia. So while James was in London, he had the chance to answer the question, what is the pathologic correlation of this very unusual water signal coming from within this dense scar? So in this patient who was 60 years old with familial hypertrophic cardiomyopathy, he underwent his initial scan, CMR scan, that was clinically done, and then 55 days later, he came back with refractory heart failure and ventricular tachycardia. They did a coronary angiogram, and it was normal. And he subsequently underwent transplantation. And so before transplantation, James acquired, the patient gave informed consent to James to take his heart and study it in the CMR scanner, and as well as to have CMR image-guided pathology done. So this is the initial in vivo images he did before he presented back with end-stage heart failure. So you can see that here's the left ventricle. He has very significant, the ejection fraction is reduced in the setting of very significant mitral regurgitation. The annulus is the mitral valve annulus is very dilated. He has asymmetrical septal hypertrophy. Here's the septum. It's thicker than the lateral wall. And his left atrium is just monstrous. Really, this is a very, very sick heart. So in the top panel images, we have our late gadolinium enhancement images. And just for reference, we have our SSFP imaging on the bottom panel. And so we can see mapped to the anterior wall, there is very significant and dense late gadolinium enhancement. It goes into the anterior septum as well as the inferior septum in here as well. Okay. So if we look at our in vivo imaging, so I'm going to show you the pre-contrast cine image. Then we have our late gadolinium enhancement image, again showing very dense scar in the anterior septum. And then again, we see that very unique imaging pattern, characteristic imaging pattern with increased T2 signal in the anterior septum that is co-registered essentially to the late gadolinium enhancement area in the anterior septum. So after this patient had his heart explanted, the heart was brought to the CMR laboratory. It was initially imaged, and T1 weighted imaging was performed. Then James injected the coronaries with gadolinium, and then washed it out with a saline flush for about 20 minutes. That must have been very, very interesting to do. In any case, we confirm in the ex vivo imaging that in these very, very high resolution pictures, you can see that very dense scar in the anterior septum. I mean, it's a really incredible image. And then co-register, the T2 weighted imaging, you can see that the area of high signal. So what is going on there in these two areas, or in this one area, I should say? So this is the important slide here to really look at to show what's going on. So if we look at area A, which correlates to this panel over here on the left, and we're going to compare it later to area B, which is on this side. So in area A, where we have both late gadolinium enhancement and T2 signal, we can see these dense lymphatic, or these large lymphatics that are coursing through dense scar. These large vascular channels. They were eventually immunohistochemically stained and found to be lymphatic channels. This has never been seen in a patient with hypertrophic cardiomyopathy, and frankly, dilated lymphatic channels has never been seen in a heart like this before. There has been increased lymphatics seen in dilated cardiomyopathies, but the lymphatics haven't been as dilated and as bizarre as this. In the areas without T2 signal, so you have LGE, you have late gadolinium enhancement without T2 signal, you can see collagen deposition and myocyte disarray, but you don't see those lymphatics. So we have the query was, were these lymphatics, this lymph tissue, giving us the T2 signal? And so when further looking at this area, in the area of scar and T2 signal, if we look at just the border zone between the myocytes and the scar, and the dense scar, this is electron microscopy. We can see a large lymph channel and abutting, or just juxtaposed right next to it, these lymphatic channels or these myocytes. And we had always thought that myocytes were coupled, and you get passive electrical communication between these myocytes through gap junctions. But the thought here is, could the endothelium of the lymphatics actually be an appropriate environment for malignant ventricular arrhythmia? You can have there actually has been research to show that you can have conduction down endothelium. So the apposition of these lymphatic endothelium and myocytes through scar can be potentially an appropriate environment for malignant ventricular arrhythmia. That is the hypothesis here. And we furthermore did some modeling with Dr. Ed Vigmans, who is in Bordeaux now, used to be at University of Calgary. And if we look at the myocardium, so in this model, the blue area, this blue sheet is myocardium. It's connected to another area of myocardium with a lymphatic strand. And we can see that if we look at the potentials, the electrical conduction through the first area of myocardium, there's going to be a delay as you go through the lymphatic strands, or the endothelium of the lymphatic strands, and into the subsequent next sheet of myocardium. And that this delay is substantial enough to be theoretically possible to cause reentry and reflective waves and all these different ways that we can cause that ventricular fibrillation can be caused. So this was a rare opportunity to obtain histologic correlation of a really unique imaging pattern. This only occurs in about a third of patients. It could be potentially a really useful biomarker. This imaging pattern has been reported by 4 different institutions to occur in a third of patients. It's been associated with more advanced phenotype and ventricular arrhythmia. And the areas of T2 signal correlate with dilated lymphatic channels coursing through mature fibrosis. And that this is a really novel finding, and it's never been found in hypertrophic cardiomyopathy before. So as is the last part of the talk, I wanted to highlight some other research that's going on in our center. This is 4D strain measurements that are in our center. We are being developed by Alessandro Satriani, and you can see. So in these diagrams, looking at 4-dimensional strain, strain looks at how the heart deforms over time. And so we're looking here at a picture of the left ventricle, and we can see the cavity of the left ventricle here. And we can see how the left ventricle deforms. This map is, well, I should say here, we can think about strain, and the heart is deforming in general 3 different directions: in the longitudinal direction, in the circumferential direction, and the radial direction. And if we can, instead of looking at the map in 2 dimensions, or 2D dimensions, we can actually look at it in 3-dimensional space. And this is a color map of the strain, and you can actually see Alessandro's hand as he moves around the heart here, and shows you all the different aspects of the heart as it's contracting through time. And I should say Mr. Vector here is a bad guy, so watch out for him. All right. So when we look at strain, so another potential imaging biomarker that could be used, and what Dr. Bobby Aderi and Dr. White and Alessandro are trying to do is to come up with another biomarker for using strain or utilizing strain. So what they found is that in patients with who have hypertrophic cardiomyopathy, if you have a lot of LGE, so this is a curve of strain versus the amount of LGE that you have. So in patients with a lot of LGE versus a little bit versus healthy controls, that if in areas that actually, so I'm going to show that up here, in areas without late gadolinium enhancement. So here's your area of late gadolinium enhancement. If you look at strain in areas without late gadolinium enhancement, we find that you have reduced strain. And I think the idea here is that in patients with more late gadolinium enhancement, even the myocardium that doesn't have enhancement is probably abnormal. You probably have more myocyte disarray in those areas. This potentially could be, though, picking up or signaling something very even different, and could potentially even be an independent biomarker. We can see that circumferential and longitudinal strain are all also decreased in these patients, as well as radial strain. So in the 2-dimensional planes, they're reduced, as well as in the principal or the total strain on the whole heart. And so they furthermore looked at strain versus scar volume and strain versus mean wall thickness, and found relationships here that were significant. The more scar you have, and the more thick your heart is, the more reduced strain you will have. So taking us back to our case, so if we think about our 19-year-old, he has new hypertrophic cardiomyopathy. So let's put him through the risk scores, right? So if we look at him through the New European Guideline risk score, his risk is 3.1% per year for over a 5-year period. And so by that risk score, he wouldn't actually get an ICD. Based on a CMR LGE burden, his risk is about 6% per year. So seemingly actually pretty high. And you might even consider an ICD in someone like that. And if you look at him by the AHA-ACC guidelines, he also would not get an ICD. So at this point, I'm clinically following this patient. I've discussed him with electrophysiologists. I haven't put an ICD in him, or haven't offered him an ICD yet, but I'm following him very closely given his burden of late gadolinium enhancement. So just in summary, most patients with hypertrophic cardiomyopathy are at low risk. Work, I think, needs to be further done to refine our ability to risk stratify these patients, and CMR is an emerging powerful tool to risk stratify these patients. And just as a thank you to James, to Bobby, to Andrew, and Alessandro who helped me make this presentation, I do appreciate it. Have a great day.
Thanks a lot, Lou. That was a fantastic overview, and it's great that you gave such a lot of background so that people can have a good sense as to why we're doing this, why we're interested in this research, and why that CMR has the potential to make a potentially big impact. And as I said before, there's a lot of interest, certainly with the multi-center registry that's going on, in trying to see how we can actually impact on patients' management and care. So maybe I'll just open it up and see if there's anybody that has any questions for Lou.